بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. Lower genital tract infection include vulvitis, vaginitis, and cervicitis. Normally, there is natural defensive mechanism protecting the female genitalia from getting infection. These levels of protection are found tabulated in front of you. During childbearing period, the vagina harbors some microorganisms called vaginal flora. These organisms cause no harm to healthy individuals. This slide shows the wet preparation of normal vaginal discharge. Epithelial cells are found with few RBCs and polymorphonuclear leukocytes. There may be occasional sperms. Normal wet preparation may also show lactobacilli, which makes the vagina acidic. This vaginal acidity protects the overgrowth of pathogens. Genital tract infections are anatomically classified as being lower and upper genital tract infection. Etiologically, genital infection may be sexually transmitted or non-specific infection due to lack of asepsis or bad hygiene, or blood-borne infection. Lastly, it may be due to endogenous infections. Vulvitis may be acute or chronic. Acute vulvitis is secondary to septic vaginitis. Chronic vulvitis may be secondary to vaginitis or caused by primary infection by TB and bilharziosis. In 30% of cases, vulvitis is non-infectious, like contact dermatitis and atrophic vulvitis in postmenopausal women and premenarchal girls. Other types of vulvitis include diabetic vulvitis and vulvitis caused by some sexually transmitted disease like syphilis and soft sore. A patient with vulvitis may present by erythema and edema of the vulva and perineum, itching, burning, dyspareunia, and discharge, with or without bad odor. Signs found in vulvitis may be redness and swelling of the vulval skin, thickening of the skin with possible vaginal discharge, and small cracks or skin lesions. Barcelonitis is due to gonorrhea or non-specific infections. The gland becomes palpable as a tender mass in the posterior third of the labia majora. Infection may proceed to abscess formation. Abscess is treated by antibiotic and drainage. Sometimes the Bartholin duct may be closed and the gland distends to form a cyst. This cyst is treated by marsupialization. Genital ulcer may be due to infection, trauma, or malignancy. Infections may be sexually transmitted or chronic. Sexually transmitted disease which cause ulcerative lesion of the vulva are included in the table, with the differentiating naked eye picture between these different types of ulcers. Vaginitis may be primary or secondary. Primary vaginitis during infancy and childhood, it will be in the form of vulvovaginitis. During reproductive years, may be bacterial vaginosis, genital herpes, genital warts, chlamydial infection, vaginal candidiasis, and trichomoniasis. Secondary vaginitis is usually due to urinary tract conditions and rectal conditions in case of fistula, infected cervical discharge, mechanical irritation by neglected battery, or chemical irritation by some drugs and vaginal douching. Bacterial vaginosis, by which we mean vaginal discharge in absence of signs of clinical inflammation, and it is called bacterial due to absence of fungi and parasites. Bacterial vaginosis is usually polymicrobial in origin, may be due to Gardnerella vaginalis and anaerobic organisms. 50% of women with bacterial vaginosis are asymptomatic. Symptomatic patient will show a complaint of vaginal discharge, which is thin, watery, homogeneous, grayish or gray in color. It may be mild. There may be mild itching or vulval burning. Also, bad smell or fishy odor after sexual relationship and during menstruation due to increased vaginal pH, which liberates certain amines. To diagnose bacterial vaginosis, we have 4 signs. These signs are called Amsel's criteria. Those with 1 or 2 criterion are classified as having disturbance of vaginal flora, and those with 3 or more are classified as having bacterial vaginosis. Vaginal discharge is thin, milky white discharge. The second criterion is presence of fishy odor or positive amine test. The third criteria is vaginal pH greater than 4.5 and presence of closed cells in vaginal smear. This slide shows the appearance of closed cells found in wet preparation from patient with bacterial vaginosis. Again, these are Amsel criteria. Patient with bacterial vaginosis must have at least 3 of the following 4 findings. Complication of bacterial vaginosis may be in the form of pelvic inflammatory disease, post-hysterectomy infection, obstetric complication in the form of PROM, chorioamnionitis, preterm labor, postpartum infection. Treatment of bacterial vaginosis may be systemic or topical. The drugs and the needed doses are listed in front of you. Center of Disease Control recommend metronidazole orally twice daily for 7 days or locally in the form of gel. Alternative regimen includes single dose metronidazole 2 gram, but it is less effective than 7 days course. Screening and therapy is not recommended for male partners. Male partner is only treated if he has symptoms. During pregnancy, metronidazole and clindamycin are safe. Vaginal candidiasis are caused by Candida albicans in 80 to 90% of cases. About 1/3 of vaginitis are caused by fungus. Predisposing factors include hyperestrogenic state like pregnancy and pill users, immunocompromised patient like diabetics, patient receiving prolonged antibiotic or corticosteroid or immunosuppressive therapy, other factors like tight, restricting, poorly ventilated synthetic underwears. This slide shows a case of vulvovaginal candidiasis. Clinical picture of vaginal candidiasis include tense vulval and vaginal itching, thick white discharge, dysuria, superficial dyspareunia, soreness and excoriation of the vulva, typically adherent white discharge red vaginal wall. Complicated cases of vulvovaginal candidiasis include recurrent cases, 4 or more episodes per year, severe cases, non-albicans candidiasis, compromised host, and pregnancy. This slide shows treatment of recurrent and severe cases. Non-albican cases are treated for 7 to 14 days by non-fluconazole therapy, 600 boric acid in gelatin capsule, vaginally once a day for 2 weeks. Compromised host are treated by 1 to 2 weeks of topical therapy. Vaginal candidiasis can be diagnosed by clinical examination, saline or potassium hydroxide 10% wet mount preparation, gram stain, pH, culture of high vaginal swab. Treatment consists of elimination of predisposing factor, topical application of antifungal agent, systemic medication in the form of fluconazole 150 mg single dose. Causes of failure are poor compliance, drug resistance, unusual fungal infection other than Candida albicans, sexual transmission from male partner, recurrent infection from GIT, and immunocompromised patient. In vaginal candidiasis, wet preparation will show polymorph nuclear leukocytes and yeast bugs. Also, pseudohyphae may be detected. Vaginal trichomoniasis is caused by Trichomonas vaginalis, a flagellated monocellular parasite. Patients with vaginal trichomoniasis may be asymptomatic in 50% of cases. Other symptomatic cases will complain of vaginal discharge together with dysuria and soreness. The discharge is of bad odor, thin, profuse, frothy, and yellowish green. Signs will be in the form of vulval and vaginal erythema, strawberry cervix, or flea-bitten cervix. Trichomonas vaginalis in men frequently asymptomatic, but in 10% or more of cases, non-gonococcal urethritis is found. Vaginal trichomoniasis is diagnosed by its clinical picture, addition of potassium hydroxide resulting in release of amines giving fishy odor in about 75% of cases. These findings are more strongly associated with bacterial vaginosis than with trichomoniasis. Wet mount preparation will identify the motile organism. Culture in some cases may be needed. Treatment by metronidazole either by mouth or locally. Male partner should receive treatment, otherwise treatment failure will occur due to re-exposure from infected partner. Drug resistance is another cause of failure. Treatment during pregnancy is clotrimazole in the first trimester or metronidazole during the second and third trimester. Center of Disease Control recommended metronidazole 2 grams orally in a single dose during pregnancy. The drug is safe. No evidence of teratogenicity. This slide shows the differentiating points between normal and the 3 most common causes of vaginitis. This table differentiates the three major causes of vaginal discharge. Atrophic vaginitis is an inflammation of the vagina due to estrogen deficiency. Simple atrophy without symptoms should be differentiated from symptomatic vaginitis. There are three stages in woman's life in which the vagina is atrophic: before menarche, during breastfeeding, and after menopause. Postmenopausal changes affect the urinary tract as well as the genital tract in estrogen-deprived women. This slide shows the signs of atrophic vaginitis. To diagnose atrophic vaginitis, you must exclude trichomoniasis, candidiasis, and bacterial vaginosis. Estimation of vaginal pH will reveal pH exceeding 5. Wet preparation and pap smear are used for the diagnosis of atrophic vaginitis. They will show some intermediate cells with immature parabasal cells in absence of mature superficial squamous. Before treating a case of atrophic vaginitis, you should exclude neoplasm, foreign body, and other infections. Treatment in the form of topical and systemic estrogen are given. Local lubricants may be used as an alternative to estrogen replacement therapy. Cervicitis is a common genital infection affecting 50% of women during the reproductive period. Cervicitis may be acute or chronic. Acute cervicitis may be due to Neisseria gonorrhea, which causes acute endocervicitis, and Chlamydia trachomatis. Chlamydia causes follicular cervicitis on top of cervical ectomy. Some pus-forming organisms like Staphylococci and Streptococci may cause acute infection following abortion, during puerperium, after cervical surgery, and in presence of foreign bodies. This slide shows positive swab test demonstrating mucopurulent cervical discharge. Complications of acute cervicitis are colonoscopy, spread of infection to the upper genital tract causing PID, and secondary vaginitis. Acute cervicitis is treated by systemic broad-spectrum antibiotic, and the choice of the drug depends on the nature of the pathogen. Chronic cervicitis is a common sequel of acute cervicitis. It is the commonest gynecological lesion. Symptoms of chronic cervicitis include persistent leukorrhea, usually mucopurulent, slight postcoital bleeding or staining, lower abdominal discomfort, lumbosacral backache, dysmenorrhea, and dyspareunia, inability to conceive, and some urinary symptoms. Signs or the pathological types of chronic cervicitis are chronic endocervicitis, cervical mucus polyp, chronic hypertrophic cervicitis, Nabatean follicle, etropion, cervical ectomy. This slide shows some colposcopic finding in some cases of chronic cervicitis. Upper row from right to left, a typical transformation zone, Nabatean follicle, and cervical mucus polyp. Lower row from right to left, cervical eversion, endocervicitis, and cervical ectomy. Treatment of chronic cervicitis include medical treatment in the form of systemic antibiotic, cauterization, and surgery. Cauterization may be chemical by silver nitrate or zinc chloride, cryocautery, electrocautery, or cauterization by laser, and it is the best if available. Surgery in the form of conization or tracheography for ectropion or cervical eversion. This slide demonstrates the technique of cervical cauterization, timing, complications, and contraindications. This slide demonstrates the technique of tracheography. Initially, excision of the cervical scar is done. Then, the raw areas left after excision is sutured to reconstruct the cervical canal. Thank you for your attention. All good wishes and good luck.